Good morning, everyone. It really warms my heart to see so many people out today for what we hope to be the first of many events to connect those whose lives have been touched by lung cancer with those who are passionate about working towards a better future for lung cancer patients in all of Alberta and across Canada. My name is Desiree Howe. I am one of the medical oncologists here at the Arthur Child. And on behalf of my colleagues here at the Arthur Child, our partners at Lung Cancer Canada, I want to extend a really warm welcome for you to come out on your day off to join us for this inaugural event. Today, we hope to inform, inspire, and I have been doing this a really long time now. And I have had a chance to see firsthand monumental changes in the treatment, diagnosis of lung cancer that have really helped our patients and families. And I can see a bright future ahead. There are so many more exciting changes to come. Before we begin today's agenda, I just want to acknowledge that I have the privilege to live, play, and work on the unceded and traditional territories of the Tsuut'ina and Nakota Nation, the Blackfoot Confederacy, and the Métis Nation of Region 3. As I speak this land acknowledgement, I really want to commit to everyone, we want to commit to everyone that in working towards a better future for lung cancer patients, we want all lung cancer patients to benefit. I had the privilege to work with the Canadian Partnership Against Cancer, the steward for the National Cancer Strategy. And a few years ago, they published this report on lung cancer and equity. It is startling to read that lung cancer outcomes are not the same for all Canadians. It differs by geography. There are some socio-demographic factors that come into play, but that should not be the case. And we really want to improve outcomes for everyone. So today you'll hear about some things that are going on at the Arthur Child. We have the privilege of this beautiful new building, but not just what's going on in these four walls, but beyond the four walls. And rest assured that the passion towards advancing outcomes for lung cancer patients knows no boundaries. It's not just within this building, the city, the province. This is the first year that nationally, the Canadian Cancer Society will launch a lung cancer action plan. So it is a strategic framework to help clinicians, researchers, governments, advocacy groups, everyone who's passionate about lung cancer work towards, in a focused way, advancing the outcomes for all Canadians. So before we start with today's agenda, I'll invite Vishal Wright from Lung Cancer Canada to say a few words of welcome.
Hi, everyone. Thank you. I just wanted to welcome you all. Thank you for coming. It's been a great turnout here in Calgary, and we hope that you are informed and enjoy and meet others today. At Lung Cancer Canada, we're committed to supporting the young cancer community and promoting early detection, advancing critical research, eliminating the stigma, and you are all part of that today. Thank you again.
We're going to hear from several different people today. We'll have a short break, and then we're also going to hear from some patients about their stories. So please join us if you have time for the whole event, and at the end, we will have lunch in the lobby. Our four speakers today, Drs. Monica Mullin, Adrian, Vishal, Navani, and Lisa Shirt, nurse practitioner, represent different parts of the cancer journey. We want to, because advancing the outcomes for lung cancer isn't just picking away at one part of it. It really is trying to work on every part of the cancer journey. So we're going to hear about cancer screening, what's new in the diagnostic workup, what's new with treatments, research, and supportive care as well. So if you have questions, there'll be an opportunity to ask each of the speakers some questions. At the break, there'll be another opportunity, and please feel free to speak up. We want this to be a safe place for conversation, dialogue about things that we may not have thought about and could do better in order to improve the experience for the patients and families whose lives have been touched with lung cancer. So to start, I'd like to introduce Dr. Monica Mullin. She's an interventional pulmonologist. She comes to us most recently from London, England. I should say that all of our speakers bring a global perspective from the care of about the care of lung cancer, because new ideas can come from different places. So Dr. Mullin, I'm really interested to hear about the updates of what's going on in lung cancer screening here in Calgary. Please feel free to share your experience from your global exposure as well. Thank you.
Good morning, everyone. Again, thank you so much for being here, and I hope that we have an opportunity for lots of questions today and lots of discussion. I'm going to be chatting about lung and specifically screening benefits in the current of Alberta. I have trained elsewhere and seen screening in other places, but we'll talk about where Alberta is today and what the next steps are. I also had a land acknowledgement included. I really do just want to reconciliation, especially in this month. It's an important thing that we acknowledge, and we want to make sure, as Dr. Howe said, all patients have equitable, especially in lung cancer where we know inequities exist. And so I'm just going to start with a brief overview, and I know many people in this room have been personally touched or have family that have been touched by lung cancer. It is still the most commonly diagnosed cancer in Canada. And although you're going to hear many, many advances today, one of the important things is that it carries a high mortality, and that's something that we are all working towards through treatments. There have been massive advances. I'm on the diagnostic side, and part of my work is looking at early detection. So how can... Oh, no. I thought I heard... Okay. I'm... Okay. This is my voice when I'm yelling. I'm sorry. I will try my best to stay at this level. I am so quiet. I will internally try not to feel like I'm just shouting at you. You can hear me now, though. Great. If I could be closer to this, I would. I was just overviewing that, unfortunately, lung cancer is the most commonly diagnosed cancer in Canada, exceeding all other cancer types, including the common ones like breast cancer and prostate cancer. And when you look at the impact lung cancer has on patients, it does carry a very high mortality beyond those other common cancer types. And these are reasons that we are all working towards improving lung cancer care and lung cancer outcomes. I am on the diagnostic side of lung cancer, and a lot of my work in research is towards earlier detection. Unfortunately, in the past, part of the reasons for this high mortality and outcomes for patients is because lung cancer presents often at a very late stage. So about 50% of the cases will be presenting at stage 4. And there's... Oh, we can just turn up my volume. I was going to say, if only I had this in real life. I think a lot of people would appreciate it. I'm normally the physician who sits right next to you so that I can speak directly in your ear. Now there's feedback. We'll just go back to this. So a question that we've asked many times is, why is lung cancer diagnosed late? And there's many reasons for this, and I won't be able to cover all of them today. But an important one is that it often doesn't cause symptoms. So the cancer in the lung won't cause you any alarming symptoms. You might not seek care, or the symptoms that it causes are very non-specific. So either patients aren't considering this a concerning symptom like a cough, or when they do seek medical attention, the providers are not dismissing the symptom, but thinking of many other more common things that cause it before we come to the diagnosis of lung cancer. And so how can we fix part of this problem? And I'm going to present to you today that I think lung cancer screening is a really big opportunity to do that. So there is a lot of evidence in medicine. We love to be guided by evidence and to know that what we're doing is the right thing for patients. There are large randomized control trials, which are really the gold standard in looking at how things work and if they work. One of the first ones in lung cancer was done back in 2010, and it enrolled over 50,000 patients. So it looked at chest X-rays every year compared to a CT scan, specifically a low dose, low radiation dose CT scan, to see if you could improve the detection rate for lung cancer, but also improve outcomes. And it was able to reduce lung cancer mortality by 20% compared to chest X-ray, and 7% in overall mortality. When we talk about screening programs, we think about how many patients do we need to look at and to bring into this program to make that difference. And so for about 1 in every 320 people who were screened, we were able to prevent 1 death because of lung cancer, which is, to put into context, a very acceptable number relative to all other screening programs. Maybe many of you have had a CT scan or have seen this on Grey's Anatomy, but this is just an example. Patients come in and get their CT scan for as to happen. So the Alberta Lung Cancer Screening Program was implemented as a rollout of lung cancer screening in the province from 2022, and the plan was up to 2024 to enroll 3,800 people and be able to assess this program within our provincial population, and help to provide some evidence for ongoing use of the program. An important component is the smoking cessation supports. That is still one of the main risk factors for lung cancer, and smoking is incredibly difficult to stop. And so these programs try to enhance that by providing support and medications to help patients quit. By no standard do I want to diminish how difficult it is to quit smoking and how much help we hope to provide in these programs. So the findings from this pilot were hopefully going to provide provincial-wide funding for the program. And the way that lung cancer screening works is traditionally it's a GP referral. So we will talk about other referrals into the program, but you would meet with your family doctor if they thought you were eligible. Similarly to other screening programs, they would talk to you about it. There is a risk calculator for lung cancer screening, which involves a few patient demographics and a history of smoking. And if you're above a certain risk threshold, then you would be eligible for screening. So lung cancer screening is not for every single person. It's not an age cutoff similar to other programs. It has to do with risk factors, and that's to balance some of the risks of finding things that aren't lung cancer and putting patients through tests that they wouldn't have otherwise needed. If you are eligible, then you would meet with a nurse practitioner to review those criteria. The screening, the risks and the benefits would be discussed, and then you'd be enrolled in the program where if you were an active smoker, smoking cessation support would be provided. You'd have your CT scan, and this would be done on an annual basis. The results go back to your family doctor to review, and if there's no concerning findings, you stay in the program. If there's any concerning findings, we review those and you get referred on to appropriate care. Now, the team did implement, and I should say, none of the credit for this program goes to me. There are many other people who have been working on this. I've just joined the group here. But they were very smart in implementing a self-referral and a self-risk calculator to look at if this was online and available to patients, could you calculate your own risk and then advocate for screening for yourself by bringing this to your family doctor. So if you look up Screening for Life, the risk calculator is there, and it will calculate and spell out if this is something that you or loved ones could look into. That's just a PDF that is generated for the referral, and that still does go through a general practitioner, but this is a step to help patients be able to figure this out independently if they wanted. So just to review some of the data, I apologize, I thought it would project a little bit larger, but this is just looking at the total number of low-dose CT scans that have been done across different sites. So this is across Alberta. There are sites in Calgary, Edmonton, as well as some more rural areas. On this slide, 4,300 patients have enrolled. The program had been extended and continues to be extended, so we're still enrolling into the program, and we far exceeded that target of 3,800. looking at the eligibility and ineligibility. So most risk calculation done and who are presenting to the program are eligible for screening. That's in the blue. And it gives you kind of a breakdown of if it's self-referral, which I think is really encouraging to see that a decent chunk of the pie is because patients were looking at this and were asking for this and receiving it. And overall, there's been just over 4,000 people at this point, which was June of this year in the program. Oh, yeah. Oh, I am so sorry. I'll just hold this up. Yeah. It's much easier than, I for that recurring theme on my talk. These slides on what people are saying. So this is a quote from a patient saying, "I'm grateful to be a part of this. It relieves my mind to know that I'm being helped to quit. I even have a follow-up CT scan that has been booked for me." And providers are also happy with the program. They feel that enrolling is easy. Hospital locations across the province have been selected in convenient locations, and support for smoking cessation. And what does the about this for many hours, but we're hoping to improve the number, to improve access to more remote parts of the province. We have been doing public consultation, and we hope to continue to do so that all of the voices are heard and represented. The provincial program implementation will hopefully come in 2026, so stay tuned. And then there's ongoing research to identify and quantify risk factors other than prior cigarette use that make people at high risk of lung cancer. Because up to a quarter of lung cancer diagnoses are in patients who have never smoked cigarettes. There are many factors that play into it. And so we want to make sure we can screen all of those who are at risk. And that is all that I had. So I'll stay there. I'm really sorry if some of you couldn't hear part of that. I'm happy to take questions now, or would you like to open time?
Questions from the audience? Some of the, I guess, space age things that they're talking about, like where you breathe into a tube, you put your in and you blow in a tube, but you can't make the same cancer. About those sorts of things, like what's the no.
So research is still ongoing. It's a very it would be a very good screening test if it could identify specifically lung cancer, because one of the risks, which I didn't touch, was that when you get a CT scan of your chest, many of sometimes nodules, the small spots in the lung, aren't cancer. So to do a test where that's not it could be beneficial, but right now it's very difficult to process. There aren't any specific markers. It's not at prime time. It's not impossible. And I hope to see things like that or blood tests come out in the future or be paired with screening scan, but we're just not there yet. Yeah, so I am newer to this program directly, so I won't have an overly fulfilling answer for you, and I apologize. Yeah, I think as with any type of new intervention, there's always a lot of funding issues and resource issues. And I think the main concern is we don't want to start a program and roll it out and not have enough resource to appropriately manage these patients. And it is being worked towards, and I think ongoing outside advocacy from people other than those already in discussions will help to push it forward. But resource limitation and kind of funding limitations have been the main issue, is my understanding. Yeah, and then we have one online. Comments are appreciated.
He talked about the variation of having no regular students, In other words, it's a risk factor for breast cancer, and that they look at me as a whole. But I was kind of conversation. So when I told Dr. Fong that I but so the hope is there.
Yeah, and I appreciate that. That is my understanding too, is that I think everyone's aligned and it just hasn't been fully green lighted yet. And the exact time for that is, I think, still in question. But a general rollout is a lot of people who are eligible. And so thinking and planning forward and making sure that the program is set up is successful, I think is important too. Sorry, I just want to do the online question, if that's okay, just so we all have a chance. So Sarah asked, what about screening for people who have never smoked? What other risk factors exist for those who have never smoked? You mentioned that. So, going on internationally and in Canada out of BC for screening in patients who have no smoking history. They're looking at risk factors like radon exposure, looking at pollution exposure, looking at family history of lung cancer. And so they're trying to define that so that we can quantify that risk more accurately and be able to enroll patients in who need it. So it is a space where we hope to see progress in the upcoming years, but we are not there yet. The question was just what can people here do to help promote and bring forward the initiative of early detection? And I think it's something where the louder the voice, the more attention it gets from the government. So writing to ministers, calling into local policy, saying that this is a priority from a patient perspective. Having meetings like this, having discussions like this are all things that will help move it forward. And I think maybe just one more question and then we'll let others speak. So that's a great question. And there's work going on out of Alberta to look at radon levels and exposures and quantifying that risk and understanding how much exposure, what's the threshold, when are we going to enroll. So right now, unfortunately, no, there is not any screening option. But it's not a question that we're forgetting about or not looking into. So I hope to have some progress to present to you in several years to come. It's important, yeah.
Our next speaker is Dr. Adrian Box, homegrown. Dr. Box did a lot of his early training here in Calgary, but also brings with us his experience at the University in Atlanta. He is a molecular and anatomical. I'll elaborate on what that is. He has been the Southern lead for molecular pathology since 2019 and the provincial lead since 2022. So thank you, Adrian, for joining us.
I can talk loud. Okay, so we're going to talk about molecular. Good for everybody? Excellent. Okay. A lot of introduction and then a little bit of discussion as to what we're doing in molecular diagnostics. Just a quick disclaimer, I'm not making any recommendations as to drug tests and appropriateness or any type of testing platforms. So really the big question on a lot of people's mind that I get whenever I talk to individuals is what is actual molecular pathology and molecular specific? So very simply, molecular pathology is the testing of a patient's tumor DNA and or RNA and assess for possible biomarkers that will help diagnose, prognose, or guide treatment towards targeted therapy. This is the concept behind precision medicine. The right drug, the right patient, the right test at the right time. And what we do, if you want to sum it up in a single sentence, that we do biomarker testing. Biomarker is essentially anything you can measure in a patient that provides some sort of clinical information. You go to your family doc, you get a glucose A1C. It's a risk assessment for diabetes. That's a biomarker. We go a little farther in molecular pathology. Genes and gene alterations in a patient's tumor might be the best course of action for these individuals. It's almost always a gene product or a gene process that's associated with the disease, and we are almost always dealing with cancer. The most common thing that we test for, there's multiple different classes of biomarkers. And the most common thing we test for is what's known as a predictive biomarker. So what this is that presence of that biomarker informs an individual as to if a treatment is going to be effective or ineffective. So you can have a positive biomarker. A really good example is EGFR positivity, means you will respond favorably to EGFR targeted therapies. A negative biomarker, such as the KRAS mutation, means you likely will not have any other alterations or respond to specific targeted therapy. So the presence of that measurement or that biomarker assessment is necessary for individuals to receive said treatment. So this is the target to targeted therapy, or what we call a companion diagnostic. So really what we're doing is we're saying that this patient has an alteration. A really good example is the HER2 antibody in individuals with cancer. These individuals, the breast cancer produces this target. The target promotes growth of that breast cancer. And so if you design a drug target to it, what happens is that you can bring those patients back to the regular prognosis. So the lower graph that we see here, you have the red curve, which is individuals which were HER2 positive and not treated with the targeted therapy. The above line, one of the green lines, is individuals who do not have that biomarker and their tumor behaved in that fashion. And the other who had the biomarker received the targeted therapy, and then this goes back to the regular baseline for the malignant. Unfortunately, cures at the moment for tumors will bring people back to the regular base so that they do much better with this. So the target, the biomarker in this instance, HER2 is the target, and the specific therapy for that is the targeted therapy. And this is the companion diagnostic precision medicine. So you can test individuals. Those individuals, their biomarker profiles will provide you with information as to what they may benefit from. It also gives you information of what they will not benefit from. So you appropriate therapies or therapies that have significant toxicity. So sub-separate them versus standard untargeted therapies such as chemotherapeutics, in which that's all based upon population data. So some people respond, the benefit, but the N of one concept, an individual, you can try and help and separate that using molecular diagnostics. So what type of molecular diagnostics are we doing at the Arthur Child here? Well, we've had a really big benefit in the movement to the Arthur Child Center. So our biomarkers previously included multiple genes, these ones listed before, very limited panel to be honest. And probably about 18 or 19 genes in total. We're not assessing for all the mutations, all the alterations. So we were missing things. All of these do have prognostic and predictive biomarkers, sorry, not all of them, most of them have predictive biomarkers associated with it. And we are doing this testing, and what we're trying to expand now is that we're moving into much larger scale assays. So you get all this information simultaneously based upon one sample from the patient. The most common assay that we use for this is called next generation sequencing. You may have seen it online and heard about it. And these allow us to do all of these tests simultaneously for individuals to provide as much information as humanly possible. Now, we've had the benefit here that when we moved into the ACC, we moved into what's known as the genome. In the past, we were really slow to this type of testing. We had NGS starting only here in 2021 and 2022. And prior, we were doing testing as individual biomarkers or separate assays, which means we may run out of specimen or tissue to test, so individuals might not get the full benefit of it. When we moved into this building here, we got the G4, and we were provided with a brand new lab and over $4 million in NGS devices alone, plus a number of other additional devices and assays that can improve our ability to perform testing. And since go live, we've actually had a very big increase in the amount of large-scale testing that we can offer. So we're going to 38% per year on year that we can offer more and more tests for more patients. We've gone from 700 tests to over 6,000 now, which represents a 600% increase in the number of tests that we can offer and perform for patients. And we're currently doing 600 of these biomarker large panel NGS per month, not just for lung cancer, but for multiple other subtypes, brain cancer, breast cancer, hematological neoplasms as well. So we're actually greatly accelerating what we can offer in molecular diagnostics. Well, came out a little weird. We're also improving the amount that we can do. So with next generation sequencing, you're not limited to one target. So the bigger machines you get, the more you can test. So on the left-hand side, sorry, you have what we were doing previously, which is the 16, 17, 18 genes. And as of Monday last week is the right-hand side that went live of our new panel, which is 358 biomarkers in a single assay. This is now the, thank you. And this is now reflex. So this does not have to be reordered by physicians. When someone wants lung molecular panel testing, we switch to this new biomarker assay for 358. This is for fusions. The most common ones that individuals will be familiar with will be ALK and ROS and FRET, of which there are targeted therapies that are very beneficial for our patients. You can read the full list. It's a lot of letters, as my colleagues like to tell me. But we're also improving other aspects of this. So in the end of this year, hopefully by the start of next year, we're adding another 309 genes to this panel. This is going to be the standard of care for lung carcinoma. So we'll have all the new targeted therapies, but we're also integrating a lot of things that are coming out in the new protocols for prognosis. So things that can say these individuals probably need more therapy or better therapy, and we're going to have a lot more. So in total, we have 309 DNA-based genes, mainly for the mutations and alterations. We have 358 fusion genes for targeted therapies toward those particulars. And then we're also expanding this out to multiple other cancers as well. And it's going to be the standard of care to move, at least in APL, as many tumors and patients to one large panel up front for everybody. It's taken a lot of effort, a lot of funding, but the access that we've been given at the ACC here with the Genome Core is really what's making this possible. The other thing I have not mentioned is that we can do way more of these tests. So hundreds of patients simultaneously can be performed on these assays, and we're trying to decrease the time it takes to get that information, because we know that the survival of individuals off of therapy or waiting for therapy is a big thing. Even a week or two is a significant proportion of that time. So the faster we get it, better you're able to get this information, the faster you can get on appropriate therapies. That's a brief summary of what we're doing here in molecular diagnostics that we try and improve. Oh, sure. So the question was, is everybody with lung cancer getting these tests, and are there gaps? Yes, unfortunately, there are gaps in this type of testing. So we do this as reflex testing from individuals who have advanced stage cancer at the time they get diagnosed by my pathology. We don't currently have large-scale panel testing for early stage cancer. We have focus testing for individuals for adjuvant therapies, but we are working to get the funding to roll this out for all new. Yes, so we've had this kind of rollout where now we have this newer panel. We have individuals who have not been tested on the newer panel. We do have provisions that individuals who have not had this testing before, or let's say they had one component of DNA and never had RNA testing, we do have the ability to go back and retest those individuals on archival samples as well, if they're still available. So ideally, no need for additional specimen samples. And then going forward, if we have requests, we'll perform. Absolutely. So first up, not research, pure clinical. We do this solely for patient benefit. The main issue is that molecular diagnostics and pathology is a hidden discipline. I interact with Dr. Howe, with Navani, with other oncologists, under clinicians. I do not interact with patients, and therefore I do not have a patient front. I do not have an advocate to government, to groups. This is my advocacy here. Because of that, labs has notoriously been underfunded. We get funding cuts or funding freezes and are asked to do 28% more year on year for these, and need to adopt newer technologies, better technologies to perform these types of assays.
What exactly is a mutant gene? How does it come about? How is it?
Yes.
come about?
So a mutant gene is any gene that has had an alteration. So the DNA sequence has been changed from the normal tissue to the tumor tissue. This can be due to a lot of different things, most commonly radiation, damage such as smoking, sometimes random, we just don't know. So those alterations cause the tumor to acquire some sort of new function, and that new function is the tumorigenesis. So it contributes to causes the proliferation. Oh, can I talk about that? Hours. Yeah. So we traditionally do it on tumor tissue, biopsy sample tissue. The main issue with that is that we need a confirmative diagnosis. The interpretation of what we see is dependent on the type of tumor. So an EGFR mutation in the lung and an EGFR mutation in the brain are two completely different things and prognose different aspects of that and different therapies. We can do it on blood, that's the new thing, cell-free DNA. That is to find circulating fragments of tumor DNA. So we're still testing the tumor per se. We're just using a different source. Every test and every assay has its own nuances, considerations, positive, false, negatives, things we have to be aware of. We try and use them. So I can assure you I did not just finish high school. It is, yeah. No. With a complete perfect honesty, we do not. The field is fairly new, particularly very new in Canada, very well established in the state. For example, we do not have a formal training program for physicians to do molecular diagnostics in Canada that has been approved by the Royal College. Does not exist. They're working on it. So all of our individuals, we have about, well, now we've hired a few new ones, 9 individuals. We all have to go to the States to get trained, well-established training. We don't have technologists to do this. We have to train them ourselves. Again, technology training groups are working on this, but there's a definitive lack of individuals and even training programs to convince individuals to do
We'll only be able to take one more question and then we can, Dr. Box will be around during the break. So
answer one question here.
Mike.
Yeah, so Sarah says, is there testing for people who say have a RET mutation and are now developing resistance? Is there further testing possible to find out the resistance is happening? Absolutely, yes. RET testing specifically, we have the ability to find RET mutations, the fusion, I should say. And we do have the ability to find some resistance mutations. There are classic resistance mutations for EGFR that we do find. They're becoming less and less important at the moment because of the new class of drugs. But we do have the capability to find resistance. One of the issues with those is it's a new test, it's another test, it's another indication, it has more money, more need, more utilization. So the more utilization we have very limited resources, very limited staffing. So some of them we can't find, and ones that become very, very new, we have to go back and redesign the panel to find them. So we try to be as upfront and as available as possible, but there are ones that we don't have, and we just need the time to develop the test and modify it as they come.
So very popular, Dr. Box. Thank you very much for offering to stay around and break. Our next speaker is my colleague, Dr. Navani. We were very, very fortunate to recruit him because he is truly a globally trained physician. He comes to us from the United Kingdom, where he did his initial training, Australia, and somehow we convinced him that YYC was really the place to stick around. Dr. Navani is not only an accomplished clinician, but researcher. He leads our Glands Look translational research program, as well as our clinical research trials. His accomplishments are so long. I told Dr. Navani, in the interest of time, we're going to have to cut it short. He's going to tell us about research here at the test.
Thanks so much, Dr. Howe. So it's really lovely to see so many faces that I see on a regular basis in my clinic and with the academic stuff that we do. So thank you all for coming and being so engaged with this disease that means so much to so many people here. These are my disclosures and a land acknowledgement statement. Please let me know if you can't hear me. A little bit about me, if you haven't met me, I'm very happy to raise my young family here in Calgary. I went to school in the United Kingdom, and then thought I'd move to Australia for a year because the UK is pretty cold and grey, and I thought it would only be 1 year. And then I met this girl who said she's from Calgary. Apparently at some point in that conversation, I said, sure, we can move to Calgary. I don't remember saying that, to be quite honest with you. But she held me to it. And then 7 years later, we moved to Calgary. And I'm very happy to be here and live here and work here with you all. Every day, medical oncologists bear witness to this disease and what it takes from patients. And when I was in training, medical school, that's how things had started, with these stormy skies, half of people dying within 1 year. We just treated non-small cell lung cancer kind of the same way, and 90% of people had died within 2 years. So things were stormy. Right now, I guess they're overcast. A bit like home back in the UK. It's grey, it's wet, but it's not a storm for most people. We have some people that can have amazing outcomes. The typical survival for ALK-rearranged non-small cell lung cancer in the metastatic setting is over 7 years now. And for PD-L1 high, another subtype of lung cancer, a third of patients live over 5 years. But that's not enough, clearly, and that's why we're here today. And we're trying to get it like Calgary, which is the funniest city in the country. We all are here for the same purpose, to try and cure metastatic lung cancer, and that's a really lofty goal. I don't know if we'll complete this goal in my lifetime or that of my children, but I think it's a great goal to have, and it's a great purpose in my life, at least. How did we get from stormy to overcast, and how will we get to sunny skies? So things start in the lab. Every new cancer treatment starts in the scientific lab with curiosity and with an idea. And then we test those hypotheses, those theories in the clinic, in patients like you who are kind enough to be on clinical trials and engage with the scientific process. And those drugs tested and proved in trials and go into the clinic, go into patients, take them and accept them into your bodies, and hopefully they improve your length and quality of life, which is the only reason that we're here in this building today. So this is a really long process. This is a really drawn out process. The complexity of this process is akin to a moon landing, with, not that we do that anymore, but with the number of people and the stages and the possibilities for error in place. To bring a new drug to market takes, around a decade from conception to approved medicine. On average, takes over $1 billion US, and 96% of drugs tested in oncology fail. So it's even less than a shot in the dark in most cases. So this is incredibly complex. I'll briefly just break it down for context here. In phase 1, we test drugs to see if they're safe. This is the first time we're doing it in humans, and I'm very excited that we formally launched a new phase 1 drug development group here at this cancer center, which I've got the privilege of leading, where we're testing across tumor streams drugs for the first time in humans, drugs that can be infusions, oral tablets, T-cell therapies, all sorts of stuff that we will talk about. Then in phase 2, we test whether it works in bigger groups, typically 30 or 100 patients. And then finally, phase 3, the final test, the final hurdle, to say, is this better than what we're doing already? And those are the longest, most complex studies that need almost 1,000 patients usually. And you can imagine how hard it is to find those patients, because to be on a clinical trial in lung cancer, you have to be the best of this. You have to have lung cancer, this really difficult disease, but you have to tick 30 different checkboxes, and your tumor has to be the right size and shape, and you can't have any other problems with other organs. And it's very challenging to find people that are suitable for these trials, because they're tested in a very restricted group of people. That's briefly the trial process in a nutshell. What are we doing here in this building? Well, through the unique opportunity that the Arthur Child provides, we have over 10,000 square feet of research space for our trials unit on level 5. And in this huge building with 12 floors, we will soon carve out a dedicated space in the systemic suite for human patients on clinical trials. And we also are grateful to have colleagues like Dr. Bock here and other labs like the University of Calgary labs from the Charbonneau here to try and do a full bench to bedside approach to try and develop new drugs here, test new drugs here, and then hopefully make drugs that work and meaningfully change outcomes. This is a big unit within our building. We have over 100 dedicated staff in the trials unit, many of which I can see here today. This is last year's data. We had over 140 clinical trials already and over 1,000 patients on follow-up. Only 41 patients were enrolled in phase 1 studies. I hope to improve that a lot over the next few years. This is still not enough. Clinical trials, in my mind, are standards of care, and I aspire for every patient that has lung cancer that's suitable for a clinical trial to be able to be offered one in this building. We don't have enough at present, but we are trying to open these trials up as rapidly as possible. Because when we can't cure the disease, in my mind, patients should be offered clinical trials. So what are we doing right now? So I'm really proud to say that we've been involved in the pivotal, that means the final phase 3 studies of many approved medications. If you're on Tagrisso, osimertinib plus chemotherapy, we did that study. Actually, Dr. Azifi, my colleague, was on the list of authors at that study, just presented at World Lung, and that's going to be in a major manuscript. This is a big deal, and we were on the author list for that. We've also been involved in the pivotal studies of Rybrevant, amivantamab, Imfinzi, Keytruda, durvalumab and pembrolizumab, sotorasib, Lumakras. We have done these studies, so thanks to your donations of your time and acceptances of those risks, you've helped in the approval of these new medicines. Right now, what are we doing? Well, we've got this little DNA double helix. We've got a genomic focus study. Dr. Howe is leading a phase 1B, so an early phase study with binimetinib and pembro for stage 4 first-line disease. We're doing studies with new drugs, antibody drug conjugates, where we're one of the highest recruiting centers in the country, and we're opening a new trial in second-line non-small cell lung cancer. And we're also trying to invigorate the immune system with our approaches. And so we have first-line trials of a new therapy modality, bispecific antibodies, where we combine drugs that target PD-L1 and CTLA-4. These are immune checkpoints that, if you block, stir up the immune system. Or we're putting those drugs in one, and we have several patients on a phase 3 study. Again, we're the highest recruiting site in Canada about that for that study. But it's not enough. So my goal is, Desiree, 10 studies open for patients by the middle of next year. We currently have 4, so we want to double that. And we are also currently in launch for 2 studies in phase 1 that would have lung cancer patients in their cohort. So there will be more options for patients very soon. What does this mean for you? Every approved lung cancer treatment has been thoroughly tested in clinical trial with thousands of patients by the time it gets into your veins. They give you access to potentially better treatments, clinical trials that is, and that your participation also helps other patients that may be diagnosed with your disease. And we're very grateful for philanthropic funding to help start our process through the OWN campaign, but it's never enough given the lofty ambitions that we have. And finally, I just want to stop there. I want you all to take your mobile phones out, please. We've all got phones. You can take them out. Take a photo, not of me, but of this QR code here, and you should have it also as well. So you can also take a photo of that or this. And if you're a patient or a caregiver for someone with lung cancer, then please undertake this survey. So we're very fortunate with my research group to get funding from Marathon of Hope for the first patient-reported outcomes study in lung cancer in Canada, called the PROPEL study, patient-reported outcomes in people experiencing lung cancer. We've already got almost 100 patients or caregivers that have done this study, this survey, and we're using this data alongside a lot of our other data that we collect through the GlanceLook research program in terms of clinical outcomes to advocate for better access to approved medicines and earlier access to approved medicines. So that's a little shameless plug for my research study as well. And I think with that, I'll stop and invite any questions.
So Dr. Navani, you could plug the study. I think it's important. A lot of the questions that have been asked this morning are about access, how we can help arm us advocate on behalf of our patients.
The first thing we were taught in
Question goes on.
Yeah, the question, why is the cohort so small in phase 1? So the first thing I was taught as I walked into medical school is do not harm the patient. So with a phase 1 study, it's a highly experimental molecule that's only been tested in cells and from animal models. So we're treating usually patients with very advanced cancer that have a high symptom burden and cannot tolerate often toxicity side effects. And so it's really restricted on purpose because we don't want to harm a bunch of people with a drug that may never work. Yeah. So it's a good question. Just if there were more people willing to take on the risk, would that be easier? Would that help things quicker? Clinical trials are created through a really careful prescription or recipe, a protocol. And they're very careful numbers in place, because these trials are designed based on statistical assumptions. How many people do you need? What are you trying to see? How many people would be meaningful to see responses in people's tumors or side effects? And so even if there are willing participants, actually, the reality is there's a queue and we have to wait and advocate for something called a slot. So often patients will be in limbo, waiting for a slot to appear on a clinical trial. And the reason is, we're testing the drug. So we don't know that we can actually go ahead with a certain dose or an increased dose before we've tested all the people already on the trial at that dose. So it's really a safety mitigating exercise. It's a toxicity mitigating exercise. Yeah. I think the regulators, the people that approve medicines, Health Canada here and Food and Drug Administration in the United States, and pharmaceutical companies and academics, just have very strict criteria, because although patients may feel that there is no other option, they want a shot, things have to be performed in a really ordered and careful way based on like a scientific approach. And as I said before, you have to be the best of the sick. And in phase 1, the first phase, you have to be the healthiest, because you have to be able to tolerate what is really an experiment, like a true experiment in real people. So I share your concerns. I love the advocacy. A lot of things could be made better through distributed trials and other approaches, but it is carefully ordered for a reason. So I didn't plan the question, and I love the question, which is after clinical trials that may take a decade, the approval process and the reimbursement takes a very long time, and that's not acceptable. So part of the reason we're doing this study is to advocate for better access to drugs once they've been approved. Canada has one of the longest wait times between approval of a medicine by Health Canada and reimbursement by the provinces. And part of what we're doing in the PROPEL study is measuring those wait times and seeing how many patients' life years could be saved if they actually got access to these drugs as quickly as our neighbors in the South. So it's part of our advocacy work. But a drug, once approved, is not immediately available. It has to go through a very complex funding process that involves deliberation by the CDA, Canada's Drug Agency, and then for approval, and then this is effective, and then PCPA, basically a negotiating body of all the provinces for the price, and then individual province approval and reimbursement. Maybe some other questions?
Yeah. Are there any online? Maybe while he's checking, when doctors Mullin, Navani, I did my fellowship in the United States too, and where we were testing new drugs. So I can speak to his comment that the earliest stage clinical trials often involve the patients who have most advanced disease, who exhausted all existing treatment options, but we still want to balance risk and benefit. Where often I've seen it portrayed in media, clinical trials, you're a guinea pig, and that is not the case. We are not trying to do things without thoughtful consideration of balancing risk and benefit. And because I'm old, I've had a chance to see a lot of the drugs that I worked on in my training develop. And many of the things that I use today the things that we tend to take at the time. So although the process seems long, arduous, it's a big hill to climb, it is possible. And in the end, there are real advances that we can use to get.
So a couple of questions. Diana's asked a question. It is, and I should have said this at the start, it's a kind of an individual question about a case, which I really can't comment on. So I'm just going to respectfully not answer that question. The second question from Janice is, if a trial of drugs shows no effect, disease progression, would the patient immediately switch to standard chemo IO? Is there any risk that the trial could potentially accelerate drug resistance? So this is a difficult question to answer because, again, it seems very specific to a case. Could drugs accelerate resistance? The data is not clear on that. It doesn't suggest that active anti-cancer drugs could then accelerate the resistance process as such. But cancers can change under selection pressure. Cancers can mutate under the pressure of an effective agent, then breeding out resistant clones, just like a bacteria develops resistance to antibiotics. That usually isn't thought to occur more quickly than the cancer just developing resistance on its own merits. And then just the final thing, if you do a clinical trial here of an investigational drug, it doesn't count as a line of therapy. So I think that's what the second part of the question referred to. If you're on a trial and it doesn't work, you would then go back into your routine standard of care therapy. It doesn't remove your ability to do standard therapy that's approved and funded, just to reassure you there's no danger of adversely affecting your access to funded drugs by doing a clinical.
Well, thank you everyone for your interest. In the interest of trying to get the documents from you, maybe we'll take a quick break. I want to take a moment just to thank the individuals who have made this event possible. First, thank you to our speakers for generously taking time out of your busy schedule to come join us today. Thank you to Lung Cancer Canada for sponsoring this event. And behind the scenes, I'm afraid they're not here, but they were at the registration desk. Shell Dean and Amanda Gibson worked closely with the Glanzlook Research Project and helped organize this event. Without their support, this today would not be possible. And of course, thank you all for coming out. Our next speaker is Lisa Shirt. She's a clinical nurse specialist with the Palliative Consult Service. Lisa and I go back a ways. Yeah. So we work together in clinic at the Tom Baker. But Lisa, I know, is a passionate advocate for patient care, for symptom management, for palliative care. And I really wanted to make sure that today we include the entire spectrum of the cancer journey. Wherever you or your loved ones are, there is a role for supportive care, and Lisa's going to tell us all about it. Thank you.
So kind of intimidating. After all that science and hearing all the exciting new advances, I feel like I'm kind of like the old-fashioned kind of care. But I am passionate about it, and so I really hope you guys could get something out of this, and I can explain why you might want palliative care. You just have to keep looking at me. There we go. So we do have some new and exciting things to talk about in palliative care. And is that okay? Yeah, you probably can't hear me. And I don't talk too quiet or too loud, but I talk too fast. In the theme of speaker problems, if I'm talking too fast, tell me to slow down. Yeah, so I want to talk a little bit about not what's just new, but what's exciting and what palliative care really means. So when I was looking around, I happened to see this quote, and I thought it was really cool, and it sort of explains what palliative care does. So we are concerned less about your underlying disease as being your big problem. What we're concerned about is your life. So how you want to live, how you want to be, what kind of person you are, what matters to you, what's important to you. And that sort of helps how we guide your treatment. We leave all the care of the cancer to the specialists, the great specialists at Arthur Child, but we want to look after you and as a person. And the other part about the palliative care, supportive care world is we're concerned with families too. So we know that hardly anybody comes as a single unit. You come together with all your package, whether you've got a big family or little family, they're part of this journey as well. And I can tell because a lot of people here aren't here by themselves. They're here with their support people. So we talk a lot about a palliative approach to care. So palliative care has a bad rap, and lots of times when they see my name tag, they make a little face of yuck because they think it means end of life care. And who wants to talk about that? But it's more of an approach to care. So palliative care, we often say anybody that has a serious illness at any point in their journey is appropriate for palliative care. We want to look at people and help them with symptom management. So sometimes it's physical things. We're pretty good at helping with pain or with shortness of breath. But we're also good at figuring out what's important to you, what gives your life meaning, and how to help with that. So sometimes that's your energy. Sometimes that's what you like to do and how we can make that possible. Sometimes it's really fun stuff like giving people air miles to go on a trip. There's all kinds of supportive things that can help with a disease. We also know that historically there's research that people that have palliative care earlier tend to live a little bit longer than people that don't. So we don't have all the fancy drugs and all the fancy treatments, but sometimes it's just giving people options and meanings helps improve quality of life and sometimes length of life as well. So this is sort of an older slide now. One of our colleagues in British Columbia, which is where I started my oncology career, we talk about palliative care and treatment with sort of working together. So at the beginning of your disease, the disease management piece might be really important. So what therapies am I going to get? What chemo am I going to get? What treatment am I going to get? But at the same time, we still might need a little bit of palliative care. So sometimes when people start their journey with cancer, they have a lot of symptoms. We sometimes see people with lung cancer that have significant shortness of breath or cough, or even sometimes it's just really low energy. So we can help there. And maybe we're not that important. We're just a little tiny piece of the big pie that you're going through at the beginning. But over time, as disease progresses, then oftentimes there's less treatment options, and you might spend less time at the cancer center getting new therapies and more time focusing on the symptom management and living your life at home. So we call it a bow tie model because we all work together, but at different phases in the journey, we have different amounts of need for each different service. So I've been an oncology nurse for longer than I've been a palliative nurse. And I didn't understand, when I was outside in the oncology world as well. But once I got into the oncology world, or into the palliative care world, I thought, palliative care does a lot of good, and I can see it now, but I couldn't see it when I was in the treatment center. So we did a study originally with colorectal cancer where we had a clinician in the clinic, and they met all the people with stage 4 colorectal cancer just to have a conversation about palliative care, offer a home visit, talk about symptom management. And it was a fairly labor-intensive intervention because somebody needed to be in the clinic, somebody needed to be poking the oncologist saying, we need palliative care. And so at the end of the study, the patients were happy, but one of the oncologists said, you guys think you're so great in the palliative world, why don't you just automatically see people? And so it doesn't take much for us to get excited to get more people. And so we thought about how that was possible. And we called ourselves Paces Automatic. We were a big group of people. We had oncologists, we had oncology nurses, we had specialist palliative care nurses, we had a social worker, a psychologist, and most important, we had 6 patient and family advisors. So mostly patients, but also families. And I think there's some in the audience today. And that was so important because as clinicians, we know what we know, but as patients and families, you see a very different side of this disease. And so we had amazing advisors who, if we got some really crazy ideas, they would bring us back down, or sometimes they'd give us the crazy ideas and we'd say, how are we going to do that? So there was a lot of planning and work, and we tried to figure out how we could make this process automatic. The medical oncologist said, get it so it's automatic. This is before Connect Care. So we thought, well, when Connect Care comes in, it's going to be this amazing thing, and it will know who should have a palliative consult. Of course, laughing works with Connect Care. It's not. So what myself and one of my colleagues did in combination with the coordinator for the lung tumor group we just look through all the clinic lists and find people that have been newly diagnosed with stage 4 lung cancer, and we call them. So as part of our project, this is what we did. And it was kind of labor intensive, but we got into the swing of it and we managed to do it pretty efficiently. And we had great support from our group to allow us to do it. So in the end, over a period of a long time, because then COVID hit, so things got a bit derailed, but we actually screened 113 patients, all with stage 4 lung cancer, newly diagnosed. Our goal was to phone within a week of their initial medical oncology consult. So we ended up reaching 81 of those patients. And we had kind of strict criteria because it was a research project. We didn't keep phoning people. We phoned 3 times, and if they didn't answer, we didn't call back. We didn't leave messages because nobody wants a message saying, "Hi, I'm from palliative care" on their answering machine. So we didn't leave messages. So in the end, we had 81 patients that we recruited to our study, that we were able to talk to them about our approach to care and then follow up with a home visit. So during the research project, it was myself and my colleague Vanessa that saw all of those people. And then we had this big research team that flew in after and did some qualitative and quantitative research. They did a lot of surveys, questionnaires. If people were happy with the phone call and the intervention, which was our visit. And then they also did some qualitative work. And what we learned from that, which Vanessa and I knew from doing the consults, was that people loved it. They loved having someone come to their house, and we talk a lot and we give them lots of different resources, not just about their lung cancer, but living with a serious illness. So how am I gonna live my life? I don't have enough energy. How am I going to talk to my kids? What am I going to say to my grandkids? What about my benefits? I don't have any money. I can't afford parking. All of the things that go along with cancer that we don't always get a chance to talk about at a cancer center. And so the results from our research piece were quite positive. We've gone on to present literally all over the place. I've presented this research in Brussels. We presented down in the States. We presented at international conferences. And people are always shocked that we would have the nerve, I guess, to just cold call people. But because it was so positively received by patients, we're still doing it. So now Connect Care still hasn't produced its magic. Vanessa and I are still looking through the list. And we're still calling people that are newly diagnosed. And so once we call people and explain our services, we offer a visit. Some people are not interested. They're not ready. It's not time. They're too tired. It's too busy. But oftentimes people say yes. We don't get a lot of no's. We're pretty good salespeople. And so once we go into people's home, we're usually there for a while, like an hour and a half often. And we give people a chance to, first of all, talk about what they're going through, and then offer all the different resources. There's so many things in the community that people don't even imagine exist. Sometimes it's really, I can think of the referrals I've done in the last couple of weeks. One was about money. Like, I had a job, now I don't have a job. How on earth am I going to pay for our groceries? How, like, have kid in university? How are we going to afford this? I've had one recently where there was very young kids in the family. How do I talk to my kids about this? They know I've got an illness that is serious. How do they manage? I can't talk to them. So there's all these community resources on top of the resources in the cancer world that can provide people with support. And it's never too early. It's never too early to have conversations, to get information. Oftentimes with these visits, it's a lot. Sometimes we'll follow up if needed. If people are really sick and needing more support, we can pull in home care teams or palliative home care teams if needed and connect people. And then we leave our contact. So I often get calls down the road, sometimes a week down the road, or sometimes 4 years down the road, to say, "I remember me," and I say yes, but I can't because I see so many people. And then we can reconnect people. So I feel like it's a little bit of a lifeline in your pile of stuff. So it gives people a chance later. Maybe they are having more symptoms, and it gives people a chance and a resource to look into when they really need to. And so this was a quote from one of our patient advisors, and I just wanted to include it because I think it was so important. When you're newly diagnosed, there's so much going on, and we worried, and we still worry a bit about the overload of adding more. But our patient advisors are very clear on how come it took us this many years to get all this information. Now I feel like I'm a knowledgeable patient and I know where to go for help and who to call for support. We wanted to give that to people earlier. So we understand it's a lot, but sometimes we know when I go into people's house, there's a pile on the dining room table with clinical trials and all the different things that are going on. But we add to the pile and we do get calls down the road. So we feel like it's a little piece for people to tuck away if they don't feel they need it right away. But knowing that there's something out there, lots of times we get a call when oncologists say there aren't any more treatment options and you get discharged from the cancer system. And that's a bit of a shock too. So having that sort of safety net of someone you can call and say, wow, I've been discharged. My cancer's not cured. What do I do now? Right? So we can help with those kinds of things as well. Great. So where are we today? So like I said, technology turned out to be not so good, shocking. But we felt that it was important. So we continue to screen. Vanessa and I still do the screening, but our entire consult service participates in the actual visits now. And sometimes because it's not such a research project, people get called a little bit later after their diagnosis, and that might be an okay thing too. So we're realizing that timing might vary, and that's okay. And we hope that further research can be done like this. This is not expensive bench research. It's not curing disease, but we feel like it's making a big difference for people, for their quality of life, for their families. Sometimes knowing what's ahead, knowing what to manage that is a really, really important piece of these and equipping people to help them cope with it is a big part of it, right? And families. Sometimes our visits are more about the families than the patients. Families are not the main consumers of all the information when you go to your oncology visit because we're focusing on the cancer and the person with the cancer. So family members often have different questions and different worries that there's just not time when you're here for your visit. So we feel like it's been very helpful for families as well. So I sent my little presentation to Vanessa and she said, you better tell them where to get referrals just in case. So if ever you were in a situation where you felt like, or somebody you knew wanted a palliative referral, we're not very fancy. You could ask your family doctor, you can ask your nurse or your oncologist at the cancer center. Or if you're really wily and you go on the Alberta Health Services website and find palliative care, you can call us if you find one of our cards laying around. Doesn't have to be anything to do with technology. You call us and we're happy to see you. And we do sometimes find families that are wading through the weeds somewhere and come across our number and cold call us. We're cool with that. We don't need anything super official. So if you know somebody that would benefit from palliative and supportive care, they can ask someone for a referral, or you can just call us and we'll make your referral happen. Yeah, so our question is always, we know it's good. How do we get it out there? So tell your friends, but talking at things like this is important. That we're working so hard to destigmatize the term and make palliative care a good thing. It can help people live their lives better. And that's what our bottom line is. That's what's really important to us. Questions? Yes. Yeah. Yeah. And it's not funny, but it's funny that we're so different than Edmonton. We have such a different system. They don't even have palliative consultants in the community that we do. So Calgary, that's one thing. We're very lucky. We have a team. When I started, there was 2 of us in the city. Now there's 8 of us. In Edmonton, there's still, as far as I know, 0. And so it's a bit frustrating. Okay. Now, patient advocates are the best advocates because they listen to you. Any other questions or comments?
Thank you very much, Lisa. I feel the same way.
palliative care is such an important function. So far we've done a lot of information and hopefully inspire, but the next portion of our program will undoubtedly inspire. So I'd like to invite our 3 patient speakers who've kindly volunteered their time this morning to join us. I'm sorry if you can't see us. We will try to speak loudly so you can hear us. Thank you all very much for joining us this morning. Please know that this is a safe space to share your thoughts. But if there's anything we talk about that you don't feel comfortable talking about, please feel free to pass on the question. I would like to start by just inviting each one of you to introduce yourselves, tell us a little bit about yourself, and then we can talk about a few questions. So, Mardell, can we start with you?
I'm Mardell McNalley. I'm a retired mom and grandma and great grandma. And I've been going on this journey not very long, but I feel good all of the time, actually. I'm not sick. I was in the hospital a couple of times, but that was from the treatment.
Just flip the slide, Mardell, to show us that lung cancer patients can live with lung cancer and some of the highlights that we'll touch on a little bit later. Thank you for that introduction. I apologize. Olurotimi.
We got it. So, my name is Olurotimi Akinlofa. I've done a lot of things in my life. At one time, I was a student pilot in the Air Force. And then I got tired of flying the planes. I went to play with computers. So I went into Air Force radar systems and navigation. And then eventually I left. And over this course of so many years, it's always go, go, go. You know how the military is? It's just go, go, go. Until 19th September 2024, and it was stopped when I got diagnosed. And I guess in the process, we'll talk a bit more, but it's been 1 year now, and it's been a very interesting year. And I hope to be able to share a bit more of my story in this little time that I have. Yeah.
Thank you.
Yes.
Yes.
Hello, everybody. I'm Nieves Blances. I guess I'm the youngest here. So I'm a mom of my 2 beautiful boys, and I used to be a day home provider. So I usually take care of small kids. And now I like my life. I think most people wanted to be a stay-at-home mom. So I just stay at home. I'm a stay-at-home mom with my 2 boys.
Thank you very much for those introductions. Can everyone hear me? Okay. All right. I think at any age and at any stage, to hear the words lung cancer is frightening. I wonder if you would each share with us what advice you might have for someone who's newly starting on this journey. And would it be okay, yes, to start with you?
Okay, sure. I was sitting there and wondering what should I say for newly diagnosed patient of lung cancer. It's a scary thing to be diagnosed of cancer. But there's like 3 things that stand out. It works for me.
Systemic treatment, Pod C, Arthur Child Cancer Center, level 66. Systemic treatment, Pod C, Arthur Child Cancer Center, level 6. Code 66. Systemic treatment, Pod C, Arthur Child Cancer Center, level 6.
So when I first found out I have lung cancer and it's stage 4, and I thought it's the end. It's the end of my life. Of course, I was crying and crying, crying. But then, these are the things that works for me. And I would like to share it with you all. And first is be courageous. It's hard and a long road ahead. And I still feel, although I get poked, I couldn't count on my fingers how many times I was poked with the needle, and I still feel scared every time MRI and CT scan, and especially if it's about time to see Dr. Howe. And sometimes Dr. Howe can feel that I'm anxious. But I just be courageous. And also second is be hopeful. I like Dr. Howe says that there is hope. So when I first diagnosed, my son was only 9 months old. And but next year he's gonna be in kindergarten. I said there's hope. That's I always tell myself that there is hope. Third thing is there's power in your tongue. So being in the clinical trial, sorry, I'm so emotional. Sorry about that. I would apologize. So being in clinical trial, there's so many like side effects or anything. And I figured that there's power in your tongue. So I always get pictured by Mai or Haley because Dr. Howe wants to. But in anyways, if there's still scabs and wounds in my head, but there's come a point that it was full of pus and wounds, and my face was unrecognizable because of rashes, and I still have like wounds in my fingers. But every time I see myself in the mirror, I always said that I am beautifully and wonderfully made, and I'm beautiful. So that gives me like strength to go for a bath, to soak my feet in vinegar mixtures with water. I've been doing that for 3 years. And that gives me confidence. I don't make I don't appear myself ugly in front of my kids, even though some people thought I am. So my kids would say, "Mommy, you're beautiful." And that makes me feel beautiful. And that gives me like strength to move on with my life, to make happy memories with my kids and with my family, to go just a simple go for a walk. And that takes out any embarrassment or shy and that gives me like confidence to, even though I look like I would say being witchcraft. But I was happy and confident to tell people when they say, "What's happened to you?" Some people would feel small, and because I feel that before, that I would hide away, but now I feel confident and tell people I have cancer. I don't feel embarrassed and shy anymore. Yeah, that's one thing for it.
Thank you for those very brave words.
Thank you for sharing that. I mean, listening to you just kind of brings everything back, right? So my story, and I guess this happens for a lot of people. I got back from a trip to BC where I had a 50-kilometer bike ride with my sons. And then I got back and they say, oh, come check this. And I go in for a check. And then they say, you have cancer. How shocking can that be? So when I got that news, I completely shut down. And typical military fashion, I'm like, okay, great, you're dying. So just make preparations and die. So I thought, okay, maybe I have 2 weeks. I'm going to die in 2 weeks. So this is fine. What can I do? And you go into this mission mode, right? You want to solve the problem. And I fell into this deep hole of depression. But one thing that happened to me, and probably why I'm sitting before you today, was in November. I was at the foothills right here in the emergency, one of those multiple emergencies, right? And I had just joined the lung cancer group, Michelle. And that was my first meeting. It was a virtual meeting. I was in the waiting room to be attended to, and I logged on the Zoom. And there was this lady that was on the call, and she shared her story. And she was describing just my exact profile. And then she said, oh, this happened 2014. I'm like, wait, what's she talking about? 2014? I thought I'm going to die in 2 weeks' time. And then for the first time, I began to understand better what was happening to me, what was happening, right? It was like an epiphany, like that experience of seeing someone say to me, I've walked this road. You can read on the internet, you can go to the Dooms group and read all these stories. But that experience of actually talking to someone who says to you, I've walked this road, is very powerful. And that changed the whole thing for me. My outlook, the way I was going about things. I know I still got the cancer, right? And I was still going through the treatment. I was going through chemotherapy. They took out a piece of my lung in the lobectomy and so many things. But the perspective changed. So that's what part of what prompted me to come out today. I want to be able to share this story. I don't know who is watching, maybe online or something, but how that one interaction transformed everything for me was so powerful. It changed my complete understanding of what was happening to me. And I'm grateful for a forum like this and all the wonderful people that have worked with me. When I spoke to I don't live with my kids, say, and when I told them about the diagnosis, and they started to cry. And at that time, I was in that depressed mood, right? But after that experience, I had to call them and like, oh, you know what? We're still going to be able to go for our trips. We still got some time to make great memories. So that changed everything for them as well. And over time, over the past 1 year, the way I approach it now is different. That mindset is different. And I began to see that there is more to life and there is more to be enjoyed about life than simply staying in that depressed state. So I'm happy to share that story with you.
Thank you. Mardell?
When I got my diagnosis, I was in to see my doctor about something else. And just before I left, I thought, oh, yeah, I wanted to ask him. I had a lump, small lump, didn't hurt on the side of my neck. I said, what do you think of that? And he touched it and probed it, and he said, well, I think we should get a ultrasound on that and a biopsy. I thought, okay, still not thinking anything else. And he phoned me about 2 days later after the biopsy and said, you have cancer. And I just sat there with the phone at my ear and I thought, that can't be, I'm not sick. Just, he must be wrong. And I couldn't even talk to him. And I'm just thinking, what's going on here? Cancer makes you sick. I'm not sick. But I guess the biopsy would be right. And it just kind of shut me down for a while. And then I thought, well, okay, let's get on with this. And my first meeting was with a nurse practitioner, and she was very, very nice and thorough. It just felt like, okay, she's not holding anything back. And then I got connected with Dr. Howe, and I feel I'm in very good hands because I get lots of information from her, and she's very good at not holding back. But I've had some pretty good results from immunotherapy, except I had very bad side effects from it. And the mass has shrunk, and it's still not spreading. It's working well, and I'm still feeling well. Intact well enough that I go for bike rides. We made a trip out to Saskatchewan twice now on the motorbike. And it's big joy in my life. My son has the bike and he's willing to take me. Yeah. And as long as I can do that, I'm good. I'm happy.
You've all alluded to it a little bit. Thank you very much for sharing those heartwarming stories. It sounds like part of the journey that's very important is the support network out there. I wonder if you could speak a little bit to who is your support network and what you recommend for others to look for support.
Well, my support is my son. He's a big support. He's thankfully self-employed, so if I need him, he can usually be there without a whole lot of problems. But I have a friend that also has been very, very good for driving me to different appointments. And I do still drive myself, but there's places like to get up here and find parking and all that. But work, I need someone to help with that. And she's just always right there. Right now, she's laid up she's had a knee operation. So she's laid up. I'm trying to help her out. She's got it sewed up pretty good for her support. But yeah, my son is always right there. And it doesn't take any begging to get him to help me. And he helps at the house. If I can't handle something, he's right there to help.
Rotimi, you spoke about support that you found online. Not everybody knows where to look. How did you stumble on that?
I want to acknowledge the great support I've had with the team here at the Auto Child and with Dr. Navani. Don't know if it's okay to say that, but that's fine. And from the very get-go, I got a lot of help and pointers, resources to what I could look up, what I could do. And one of those was linking up with the lung cancer group, the one that I was talking about, Michelle. So that has opened up pathways to other support systems. Like by linking up there, I've gotten more information about just how to navigate the support system. And I also acknowledge support from like family, like my friend first, and then my partner. I said friends specifically first, and then partner. So who never gave up on me, even when I essentially gave up. I like completely disconnected, right? I'm like, what's the point? You just go away, you know? But she did not give up, and that was very helpful. So, and then from my kids, when I do get to see them, I get a lot of support from that, and I'm grateful for that every day. And like I said, you get connected to different resources out there, and you get to know every piece of information helps you just to navigate this road better. Yeah.
Yes. Do you have any suggestions about online, local, where can patients turn for support?
So the support online I joined. So when I first diagnosed, I stumbled upon the lung cancer Canada because of course when you are diagnosed you wanna find out your prognosis and people that survive for a long time. I think I recognized one of the advocate him once. Are you? Because I always see his name pop up on that Lung Cancer Canada, and I've read his stories. So I love reading cancer patient stories on that group and their treatment that works for them and their advices or their symptoms and also and I like their advices. I like reading those. I'm much of a reader. I don't give advices, so I just read. And also I joined the amivantamab group. So there's a group as well. I just found them on Facebook. Because once you join the group, there's like suggestions of group. So I join as well. So I see people. I've read their stories as well, and they're asking for what works for their symptoms, like medicines or anything. And sometimes I would give what works for me, like that controlled my side effects. So I would give advices too here and there. So yeah, and also I would like to acknowledge as well that I have a big support from my family, from my church, and of course from my faith, and of course from my medical team, Dr. Howe. I always tell my friends that it seems like Dr. Howe has become my friends and my family, and I have great. It's a hard take to be a cancer patient, but you know that you have that good medical team. You feel like, I know it's not something to say looking forward to go to, but I have very kind nurses, Haley and Mai and Atelija. So yeah, coming here, it's like coming to your extended family. So yeah.
If each of you could say one thing to the leaders, policymakers, doctors, researchers, cancer advocacy organizations, what would you tell them to help you and other cancer patients? I know that's hard. One thing, right?
Yeah.
You go
I
ahead.
should go first. I would definitely advocate for the early screening program that we heard earlier today. And I say that because I think, like in my own case, it was by chance that it was discovered. The very first time I came to the clinic here was I was being scanned for something completely different. I had gas in my stomach. And then they were scanning the stomach and they said, oops, we saw something there, you know? And then they tracked it for 2 years and no change. And they say, oh, fine, it's nothing. That was from 2020 to 2022. And then in 2024, it was also, I went to the hospital for a different thing. And they did the CT scan. And it was in that CT scan, they compared what they saw on the screen with what they had previously in my file. And that was how they were able to determine that there was a change. So if there had not been that history, it would probably have been harder to, pick this up. And probably it will have been a different pathway for me. So if there's one thing I would really advocate for, is to establish that early screening and to make it more accessible to more people. Yeah.
No?
I have to agree with them. I did get, I feel I was caught early because not being sick, I hadn't had to ask for any x-rays or scans or anything. But with that little lump on my neck that wasn't bothering me, and I don't know why I even asked him that day, but I thought, just find out what he thinks. And he had it checked right away. And I got help right from the start. So early scanning, early detection is very good.
I'll put a plug in for very good family doctors too.
Yes.
So I agree with them as well, and also I've heard one of the people asked here that they get screened only for lung cancer if you're like smoking, and what if you have like a history of like, because my dad passed away of lung cancer way back in 2019, and as soon as I came back here, I told my doctor that, because I didn't know that lung cancer was not part of it. Because I know if you have like breast cancer, you can get screened. So I went to her and said, I want to get screened because my dad passed away of lung cancer. So she said that, oh, you're not going to get lung cancer because you're not smoking and you're away from your family like 20 years ago. Oh, and your dad had lung cancer because he was a smoker throughout his life. And yeah, so that's why I hope that people that have history of lung cancer will get screened as well. And I would like to say for the leaders and the advocate people, the doctors, that I am grateful and thankful for all the work that you do.
If I may just quickly add, because I don't know who's going to watch this, maybe the premier or, but just as she said, I have never smoked in my life.
Yeah.
In fact, I have a pet peeve. Like when I was growing up in Aberdeen, Scotland, when someone is smoking in front of me on the street, I can't breathe. I run ahead just to get that person. So that's how it's been for me. I've never had alcohol in my life. So, but then this diagnosis came, and I asked the surgeon, I'm like, tell me, you have all these statistics. How did I get this? And he said, I can't tell you. It's just bad luck. So it's very important to consider this in establishing that screening program. It doesn't just have to fit a profile. We have to make it available for everyone, because the earlier you catch this, the better the outcomes.
Absolutely.
What about secondhand smoke?
Yeah.
Is that just as bad as?
Yeah. So, although smoking is the #1 risk factor for lung cancer, as you've heard about this morning, there are other risk factors, and there are still things we don't know about. About 10 to 15% of lung cancer happens in lifetime non-smokers, and we're not sure. So, as part of my own pitch for advancing the future for lung cancer patients is to try to work on the science and our understanding of why things happen. There's lots of things we still don't know. The longer I'm in medicine, the more I realize the number of things we don't understand. But everybody that's working in a lab with animals, with patients, is working to try and understand what we don't know today. And as I alluded to earlier, I have seen those firsthand improvements. I know that there's lots of other patients, family members, supporters in the audience. I want to open up the floor if there's anyone else who wants to share a piece of wisdom, a comment, a question before we wrap up. Over.
By mistake. For my actions.
I'm assuming you're asking about a non-smoker whose diagnosis comes up because I am not aware of any specific monitor.
We know the exact number.
Yeah.
Quite high.
It is not uncommon, even in someone who has had a smoking history, to have a diagnosis come in a roundabout way. Maybe you had an X-ray before planned surgery, or you're being investigated for heart disease. Or so quite often, no matter what your background history or risk factors are, diagnosis does come in a unexpected manner. It's a
my doctor, and when I found out I had cancer, I had this pain in my chest, and I went and got an X-ray, and I waited for like 3 hours for the doctor to come back, and he just walks up to me and he goes, "Looks like cancer." And then the next thing I know, I'm seeing a physician at Foothills, and they're saying, "I think you have stage 3 cancer, and it's treatable." And then from there, I get to meet Dr. Howell and her associate at the Holy Cross, and I'm in this light, and the doctor comes in and says, I said, "Yeah, I'm here for stage 3 cancer, and you're gonna cure me." And he goes, "Do you want the truth?" I said, "Yes." So they told me I had stage 4 of cancer. And I went, "Holy shit, how long do I got to live?" And Dr. Howell's associate said, "I don't know, maybe months." I go, "Holy crap." And the next thing I know, I'm going for a biopsy, and then they found I did a PET test in my throat. It's HPV, and I go, "I got cancer from having sex." What the hell? That's I'm Dr. Howe says radiation and chemotherapy and immunotherapy and 182 visits later, I'm again with something on my adrenal gland. It's cancer, obviously, but like the lady said, I never got sick from any treatment. Nothing. It tells me, so you don't look like you got lung cancer. You look healthy, and I think maybe that's why I'm doing so well, because I keep so busy, keep my mind up in it, just like my friend over there who's shut down. I used to be driving in my truck and go, all of a sudden, I'm just bawling my eyes out. I'm like, what the hell is going on? You know, and my wife, she just lost her mind. She's still messed up over it, but I'm still living next to this one.
Aw. Everyone's going to make me cry. Anyone else have something that they would like to share? Oh,
Dr. Howe is my oncologist as well. He's my lifeline. I will say this is relatively new to me for about the last 6, 7, 8 months. And I honestly didn't think I would make Christmas because it's metastasized for terminal lung cancer for brain and bone. But even today, I've come away with more hope because I used to always think terminal cancer, that was a term that used. So I'm feeling now that I can serve instead of thinking I'm going to die tomorrow. I have opportunity to live a few more years.
In the interest of time, if there are more stories to share, maybe we can all share them over lunch. Thank you so much to this morning, and a special heartfelt thanks to patients who shared their story, but in particular to Mardell, Olurotimi, and Nieves. I wasn't kidding that you all made it warmed my heart. This was a tremendous outpouring support from the community to gather around and advance. We want to hear your voices. This is a one-day event, but you're welcome to or open to hearing your feedback at any time. Please reach out to us. We want to work towards the outcomes that are important for you. Vishal.
Yes, absolutely. The goal of this is to bring everybody. Just going to lower the volume a bit so we're not feedback. But the goal of today really is, for you to hear from these experts and have access to them to ask questions, but also just to share and come together as a community, right, and meet each other. And learn about our programs too. You can see how powerful it is to just connect, right, and be it in person here or online through some of our programs, or we program where we can match you personally with someone who shares the same diet. But it's all about just, we want to hear your voices. We want you to be supported and to feel part of the community. There's too much stigma around lung cancer as it is. We need all the support and warmth in each other. Thank you.
There's a link online to Lung Cancer Canada's resources. In November, there will be an evening of hope to help raise funds for lung cancer research. And this past year is the first ever Give a Breath 5K walk here in Calgary. We had over 160 people come out. So our hope is that this event will continue to grow and help advance all the things that you heard about today. If I could just take a moment to ask our speakers at the end and the patients, to Vishal and Amanda, just to come for a group photo at the end. Thank you very much again